এটা কি লাইভ হচ্ছে এখন? শুরু হয়েছে?
ম্যাডাম আমরা লাইভে আছি।
ওকে। হ্যালো, আসসালামু আলাইকুম। আমি ডক্টর নাহিদ নাজনীন, সবাইকে স্বাগত জানাচ্ছি আমাদের প্রথম একাডেমিক ওয়েব ডিসকাশনে। This program is organized by Bangladesh Society of Diabetic Practitioners, that means BSDP, and this program is sponsored by Aristo Pharma. Today our lecture topic is Diagnosing Dysglycaemia, and speaker হিসেবে আমাদের সাথে আছেন ডক্টর ASM রিজওয়ান। Dr. ASM Rizwan graduated from Shohid Ziaur Rahman Medical College, Bogura at 2008. Then he pursued his career in internal medicine and achieved his fellowship from BCPS at 2018. Currently, he is working at Abdin Medical College as Assistant Professor of Medicine. Dr. Rizwan has a good deal of research papers which is published in various national and international peer-reviewed journals. He is also as an editor of a prestigious journal. I also like to add that he is one of the founding member of BSDP. Let's welcome Dr. ASM Rizwan.
Thank you, Dr. Nazneen, for those kind words. Assalamu alaikum, dear audience. Good evening. So I hope you all are coping well amidst this COVID-19 pandemic crisis, which has affected more than 87 million people throughout the world and has claimed almost 2 million human lives so far. So we are rightly terrified about this infectious pandemic, and the fear is high. If anyone sneezes today, he is afraid of death. On the contrary, if we look at another pandemic which is non-infectious, diabetes mellitus, which has been plaguing our world for centuries, if not for thousands of years. And as we speak tonight, 463 million people are living with diabetes. The number is projected to go as high as 700 million by 2045. And in a research which was done back in 2016, it was shown that 1.6 million people were dead, and their death could be contributed directly or indirectly to the diabetes. And we have to be aware of the fact that all these data are derived from the area which is known to us. So as we know that 95% of the patients who are suffering from diabetes belong to the type 2 variety of the diabetes, and a good bulk of the patients who suffer from the type 2 diabetes remains undiagnosed. So basically what we are looking at is the tip of iceberg. If we fail to take proper measures, this is what happens. Look at this graph. Back in 1980, the global prevalence of diabetes was 4.7%, which from that standpoint has steadily increased. And today we have a global prevalence of diabetes 9.3%. In our homeland, 7.1 million people are diabetic, with almost the equal number of undetected cases. And in a research which was done in 2015, 129,000 people was found to be dead due to the complications of diabetes. So diabetes never gets old, and it is never unimportant to talk about the diabetes. We have to be aware of the importance to talk about the diabetes and to spread the awareness related to diabetes. So tonight, I want to be focused on the glycemic variants and how to diagnose these glycemic variants and some of the caveats related to the diagnosis of glycemic variants and the implications of the pre-diabetic conditions. So the blood glucose level of a patient, which is known as glycemia, if it remains within the normal reference range, it is known as euglycemia. And on the two very extreme of the glycemic range, one is hypoglycemia, which means below the normal reference range, which is a very serious medical condition, a medical emergency. And the others on the other spectrum, we have hyperglycemia. But hyperglycemia has many facets and it includes terms like stress hyperglycemia. But what we want to discuss tonight is a specific term, dysglycemia, which includes specifically impaired fasting glucose, impaired glucose tolerance, and the diabetes mellitus. Impaired fasting glucose and impaired glucose tolerance, however, they form a different entity known as prediabetes, or as the World Health Organization call it, intermediate hyperglycemia. In many societies like ours, the diagnosis of diabetes is stigmatized. So, from the patient's perspective, it is feared whenever a person is labeled as diabetic. He thinks that his freedom of inactivity and his freedom of indulgence is lost. So we need to be meticulous whenever we are trying to diagnose a patient with diabetes, because that diagnosis will stick to the person for life, and it has not only huge physical and mental impact, but also socio-economic consequences. Let's have a look into the case of Mr. X, who is an otherwise healthy person and is worried about his recently performed urine routine examination, which shows that he is passing glucose through his urine. So he also has done a random blood sugar test, which shows 12 millimole per liter. He is pretty sure that he has diabetes because he has glycosuria as well as hyperglycemia. What's your call? To know whether a patient has diabetes or any other form of dysglycemia, we have four standardized tests, one of which is random blood sugar, and the other tests are fasting blood sugar, 2-hour post 75 gram glucose, which can be part of OGTT or oral glucose tolerance tests. And the last but not the least is hemoglobin A1C, which is a newer addition but is becoming increasingly popular and widespread. We have to follow a rule of thumb while diagnosing a patient with diabetes. That is, if the patient is symptomatic or is presenting with hyperglycemic crisis, then a single test like random blood sugar is enough to make the diagnosis if it is above the threshold point of 11.1 millimole per liter. But if this is not the case, we have to repeat the test. That repeat test can be the same test as we have done before or a different test among these four. And urine test is not considered as a diagnostic tool for diabetes. So back to the case one, his glycosuria is none of our concern, and as he is an otherwise healthy person, he should not be labeled as diabetic. He should not be regarded as healthy until he has done some repeat testing. Mrs. Y is another patient who takes care of her 60 years old diabetic mother at home, and as she has access to her glucometer, so she checks her own blood sugar now and then. Now, this morning she has found that her blood sugar is 7.5 millimole per liter, and she is concerned that she has diabetes. Regarding this case, we should know that when we are trying to diagnose we should only use the venous plasma sample. If we are taking care of a patient who is already diagnosed with diabetes, we can use the capillary blood, which is used by the glucometer. But whenever we are trying to diagnose a patient for the first time, we have to use the venous plasma because plasma glucose is 11% higher than the whole blood, and the glucometer variability is very high. So it can give us a falsely reassuring or fear provoking result that we do not want. How do we diagnose a patient as diabetic? If the fasting blood sugar is more than or equal to 7 millimole per liter, or random blood sugar or 2 hours post glucose is more than or equal to 11.1 millimole per liter, and the hemoglobin A1C should be more than or equal to 6.5%. And once again, these tests should be repeated at least twice. This is the diagnostic criteria which is used for non-pregnant adult persons. So, what should be the decision for Mrs. Y? Number one flaw in this case is that she has used glucometer, which is not an accepted test for the diagnosis of diabetes. Number two, on one occasion, she has found that her fasting blood sugar is 7.5 millimole per liter, which of course is above the threshold level for the fasting blood sugar, but she needs repeat test. So she is neither diabetic, she is not healthy. She needs just a standardized test repeated twice. Now, at this point, the audience may wonder about how the diagnostic blood levels are obtained. Why these figures? Why, from where we have got these figures? Why fasting blood sugar more than 7 means diabetic? Why the fasting blood sugar less than 7 mean the patient is not diabetic? These figures were derived from the risks of microvascular complications. So if a patient has a fasting blood sugar of 7 or more, then their risk of developing the microvascular complication related to diabetes gets high, especially retinopathy. And of course, the normality of the diabetes, the normal distribution of the glycemic range is derived from the population distribution of the plasma glucose. There is another case. Now she is pregnant, carrying her second child, and during her first pregnancy, which was 4 years back, by the way, she was diagnosed as GDM case, and afterwards she felt healthy, so was never tested for diabetes again. And 1 year back, her father was also diagnosed as a case of diabetes. Now she is pregnant for the second time, and she is uh, presenting in an antenatal clinic at 12 weeks. What should we do regarding this patient? And there is a clue that during her first pregnancy, she was screened during 25th week of gestation. Because we know, according to the standard protocol of gestational diabetes mellitus, we should screen patients whether they have gestational diabetes or not during 24 to 28 weeks of pregnancy. So rightfully, she was screened during her 25th week of gestation. But now, as she is earlier, she has presented earlier at 12 week of pregnancy. What should be done? Regarding this, the American Diabetic Association has this pregnancy protocol published recently in 2021 guideline. And on the contrary to the previous recommendation, now ADA recommends that if a lady has high risk of diabetes, in that case, OGTT should be performed at the initial antenatal visit, on the contrary to the previous recommendation of 24 to 28 weeks. So we shouldn't wait for 24 weeks if the risk of diabetes is high. And after doing the OGTT, if the patient meets the diabetes criteria, in that case, she should be labeled as diabetes complicating pregnancy, not gestational diabetes. This is a change which has taken place in 2021 guideline of the ADA. So Mrs. Jed should undergo OGTT in this visit. She shouldn't wait for 24 weeks to come. Now look at the diagnostic criteria for gestational diabetes. It's a bit different from the other forms of diabetes. The differences are you can only diagnose gestational diabetes by one-step or two-step approach, but I have presented here the one-step approach because this is the widespread and this is more convenient. So one-step approach is basically an OGTT test. You cannot diagnose gestational diabetes based on the other tests that we have, like the hemoglobin A1C or the random blood sugar. So we need an OGTT to be performed to diagnose a case of gestational diabetes. This is number one. Number two, you can see that we have a 1 hour reading here, which is not present in the traditional OGTT. In OGTT, we usually see the fasting and 2 hours, but in gestational diabetes, the 1 hour value is also important. And these values are all derived based on the adverse fetal and maternal outcome risk. Now, let's dive into this individual tests and what are their importance. As we have already mentioned, the random blood sugar can only be used in a symptomatic patient or a patient who is in crisis. And the benefit of the random blood sugar is it is a very casual test. It doesn't need any food restriction. It can be done at any time. So at a point of care, this is a very good test. We have some difficulties with Mr. A, which is a 45 years old, asymptomatic, busy CEO who wants to screen for diabetes. He doesn't have enough time to wait for 2 hours for OGTT to be completed, and he insists you to do only the fasting. Is it all right to comply with his request? Now, as you see, we have three different choices here. We can do the fasting blood sugar alone, or we can do the 2 hours post glucose alone, or we can combine to do OGTT. OGTT or oral glucose tolerance test is the all-time favorite of World Health Organization, but the ADA standpoint is inclined towards the fasting blood sugar over OGTT. Why? Because ADA argues that the fasting blood sugar is more convenient, less time consuming, and less costly than OGTT. But the argument of the World Health Organization is that DECODE study has shown that among all the participants who took part in the DECODE study, 40% met the criteria for diabetes based on their fasting blood sugar level, 31% met the post glucose level, and only 28% met both the criteria. So, fasting blood sugar will fail to diagnose 30% of diabetes. That's a huge number. If we do only the fasting blood sugar, if we rely only the fasting blood sugar, we can miss this 30% of the patient who are really diabetic. But we have failed to recognize these patients because we haven't performed their 2 hours post glucose. Moreover, 2 hour post glucose has some prognostic value too, because it was shown that 2 hours post glucose is associated with worse prognosis in comparison to the fasting blood sugar alone when you consider the mortality and retinopathy. So there is some places for OGTT. OGTT is the only mean to diagnose IGT. OGTT is required for diagnosing gestational diabetes, as we have just seen, and OGTT needs to be performed if we do not want to miss those 30%. But OGTT should not be done very casually. It requires a meticulous preparation. Why? Because if the patient doesn't take 250 grams of carbohydrate for the previous 3 days prior testing, then starvation hyperglycemia can affect the post-load level, and at least 8 hours of fasting before the test is required. Why? Why so many precautions during OGTT? Because we know that only the oral glucose can exert the incretin effect, not the IV glucose. And regarding the amount of anhydrous glucose, the 75 gram glucose is now considered to be standardized amount, but previously different amount of glucose was tried to work out with the diagnosis of diabetes, like 50 gram and 100 gram. But nowadays the 75 gram is standardized and is used worldwide, except for gestational diabetes, uh, where we can use some different amount of the glucose based on which standard criteria you use. But anyway, why the 8-hour fasting is required? Because carbohydrate continues to be absorbed in our body for 5 to 6 hours. And the cause behind the 2 hours post glucose is that when we take carbohydrates, it starts to rise the blood glucose level as soon as 10 minutes after starting the meal, but it always drops back to normal if a patient is healthy, if a person is healthy within 2 hours of completing that meal. I wanted to mention this fun fact that OGTT is not only used during the diagnosis of diabetes or gestational diabetes, it is also a cornerstone for the diagnosis of another endocrine disorder, acromegaly. Now, hemoglobin A1C, this is relatively newer, but it is getting more and more popular day by day because of its convenience, and it is a glycated hemoglobin which shows long-term glycemic control of the patient over the past 2 to 3 months, and it also doesn't need any fasting, and it has less biological and day-to-day variability. So from that point of view, the hemoglobin A1C is really a good test, and as you can see that it is superior in comparison to the fasting blood sugar in correlating the cardiovascular disease risk of a patient. But the problem with hemoglobin A1C is that if we cannot use standardized protocol and standardized machine, in that case, the hemoglobin A1C result can be erroneous. And of course, it is costly and out of reach for many patients in socially deprived and economically constrained population like ours. And it cannot be used during pregnancy. And there are some conditions like the hematinic deficiency, CKD, where it can be falsely high, and there are some conditions where it can be falsely low. So during interpretation of the hemoglobin A1C, we have to consider these many parameters which can affect the test result before concluding on the hemoglobin A1C. Now here's a doctor who is a bit confused about his patient who has done two tests. One is hemoglobin A1C, which is 6.8%, which is on the range of diabetes, because we know if the hemoglobin A1C is 6.5% or more, then we can label the patient as diabetic. But the fasting blood sugar is 6.7, which is in the range of impaired fasting glucose. So, according to the rule of thumb previously mentioned, if I want to diagnose a patient as diabetes, I have to perform two tests, either similar test or different test. And if the both tests declares that the patient is diabetic, then there is no problem. But what happens if the two tests doesn't match? So what do we do if we get this sort of discordant result? In this case, we have done two different tests, and it would not be a problem if the two different tests are high. But the problem is when one test is high, one is not. In that case, we have to repeat the one test which is high. So in this case, we have to repeat the hemoglobin A1C. And if that repeat hemoglobin A1C is also high, then we can label the patient as diabetic. Now let's talk about prediabetes. Prediabetes is the area where we can prevent diabetes, where we can talk about the prevention of diabetes. As the old adage goes, prevention is always better than cure. So we need to work on this field because prediabetes patients are really not diabetic, and this is a reversible condition. And this is very important for the clinician perspective because if we can disseminate this message to the patient that if you have pre-diabetes, you can very well be go back to the normality. So pre-diabetes is defined as hemoglobin A1C 5.7 to 6.4%. And the term pre-diabetes is preferred by American Diabetic Association, and it is not the stance of the World Health Organization, who prefers to call it intermediate hyperglycemia, because World Health Organization thinks that if you label a patient as pre-diabetic, then the patient can be stigmatized, and it is fear-provoking, and the patient may think that they are very near to diabetes. So intermediate hyperglycemia is preferred, but the ADA argues that prediabetes is more straightforward, more clearer, and it conveys the message more better than intermediate hyperglycemia, which sounds like a creepy technical term. So, prediabetes is a reversible condition, and we should work on it. If we do not act properly, in that case, the pre-diabetic patient can move forward to develop diabetes. 37% patient may develop diabetes in 4 years. And irrespective of their development of diabetes, pre-diabetes and diabetes are common in one thing, that pre-diabetes also has increased risk of cardiovascular morbidity. As we have already discussed, prediabetes includes two terms, impaired fasting glucose and impaired glucose tolerance. Now, impaired fasting glucose is defined by ADA 5.6 to 6.9 millimole per liter, which is a bit lower threshold in comparison to the World Health Organization, who defines impaired fasting glucose as 6.1 to 6.9. This condition is typically more common among male in comparison to the female. Now, why this diagnostic discrepancy between the World Health Organization and the ADA? Understandably, if we use the ADA cut point, it will diagnose more patients with impaired fasting glucose uh, in comparison to the World Health Organization criteria. But it doesn't mean that it is better, because it was shown that the impaired fasting glucose criteria used by World Health Organization has more association, more clear association with future onset of the diabetes in comparison to the cut point used by ADA. And what happens in impaired fasting glucose is that the patient loses the first phase of insulin secretion in response to the IV glucose. This is the initial point of their abnormality, which can ultimately culminate into the frank diabetes. So this is a chart, this is a graph which shows how the World Health Organization criteria and the ADA criteria can diagnose impaired fasting glucose. Impaired fasting glucose diagnosed by ADA criteria is much more than the criteria used by World Health Organization. Now, impaired glucose tolerance needs 2-hour post-glucose to diagnose, because 2-hour post-glucose, if it is between 7.8 to 11 millimole per liter, then it is called impaired glucose tolerance. If it is 11.1 or above, then the patient is frankly diabetic. The Fungatas diabetes study is a very famous study which shows that impaired glucose tolerance is a risk factor for the cardiovascular disease. They have shown that in their study, the patient who had impaired fasting glucose only doesn't pose the same cardiovascular risk. So, to wrap things up, I have three take home messages for my audience. Dysglycemia is really a common condition, and globally, 25% people are physically inactive. You know, this is the only time in the history of human race where we are living in a obesogenic condition. Previously, our ancestors had to work really hard to put some food on their table, but now the reality is we almost have everything in our fingertip. So this physical inactivity is promoting this obesity pandemic, which is promoting the diabetes and dysglycemia and whatnot. So we should take steps to prevent the dysglycemia. which is the precursor of diabetes. Stay home, stay safe. Thank you very much.
থ্যাংক ইউ ডক্টর রিজন। ধন্যবাদ সবাইকে আমাদের সাথে থাকার জন্য। আশা করি আজকের আলোচনাটি আপনাদের ভালো লেগেছে। ইফ সো দেন প্লিজ লাইক, কমেন্ট অ্যান্ড শেয়ার। আমরা আশা করি পরবর্তীতে এরকম রেগুলার বেসিসে একাডেমিক ডিসকাশন চালু রাখবো। So if you are interested to know any specific topic, then just let us know. We'll try to arrange accordingly. Now I got an announcement about next lecture. It is on 29th January, 9 p.m. Bangladesh time, and the topic is pathophysiology of type 2 diabetes mellitus. So আশা করি সবার সাথে আবার দেখা হবে। নিরাপদে থাকুন, সুস্থ থাকুন। আল্লাহ হাফেজ।